Today we have the chance to have Dr. Laurie Grier, who all of you are familiar with, so I won't go into her qualifications and experience, other than say she's going to talk to us about something that is the bane of the existence, other than surgeons, of medical critical care people, and also bane of the existence of surgical critical care people, and that is sepsis. It's part of an ongoing program at the Critical Care Society to basically minimize this effect or this problem in our ICUs. The fact that it has a separate program dedicated to it tells you exactly how serious the problem is. Before we start, however, I'd like to thank our sponsors who are responsible for lunch, and you all know that come here regularly that we don't get to serve lunch very often, and that's the folks from Actolion and also from LifeCell. Jane isn't here, but they've left some material. Well, Laurie?
Thanks. Can you guys hear me in the back? Everybody good? Thank you. About once a year, Dick asked me to come and give a specific lecture, and I usually give this lecture to the incoming pulmonary critical care fellows. I know some of you have heard some of it before, some of you have heard all of it before, but it's one of those things that we see every single day in the ICU, and it doesn't matter which ICU we're in. We're all going to see it, and therefore it's a good review, so please be patient with me as we go through it. Now, one of the things that I think is extremely important as I look at some of you in the audience, some of our younger clinicians, is Vernon's Law. And basically it states that experience is the worst teacher. It gives a test before presenting the lesson. And basically what happens is you start your residencies, you walk in, you're thrown into the ICU, and you're expected to be able to do all this without being taught how to do it. So we're going to try to cover all of this now so that as you start seeing these patients, as you get older, you know exactly what to do and how to do it. So our objectives, we're going to go through severe sepsis, and we're going to talk a little bit about resuscitation towards the end. As I told Dick, I've got about 150 slides or so. Yeah, sure can. Is that okay? Okay. As I told Dick, we're going to go through as many slides as I can get through in the time frame that we have, and if not, then we'll just have to add a second lecture later on in the academic year. So, according to Sir William Osler, there are in truth no specialties in medicine, since to know fully many of the most important diseases, a man must be familiar with their manifestations in many organs. This is sepsis, pure and simple. He didn't know what he was talking about at the time, but this is sepsis. It affects every single organ, and it affects people across all socioeconomic realms. It doesn't matter how strong you are, it doesn't matter how pious you are, and it doesn't matter if you're a little green frog. Sepsis will get you. Every one of these gentlemen developed pneumococcal pneumonia, every one of these gentlemen developed severe sepsis, and every one of them died from it. So it doesn't matter who you are, it can affect you. We've all seen this patient laying in the ICU. They come in, they have multi-organ dysfunction. As you can see here, he obviously has cardiovascular. This is an older picture, so he's got a PA catheter. He's got respiratory, he's on the vent. He's probably got some sort of nephrologic problem. He's got edema. You can see his thrombocytopenia from his rash, altered mental status as he's tied down. Multi-organ dysfunction secondary to a simple disease process, severe sepsis. It is a major cause of morbidity and mortality in the United States. It has moved up from number 11 to number 10. The only thing that causes more problems for us in critical care is cardiac. So outside the non-coronary ICU, it is sepsis. And if you think you're not going to see it, you're wrong. Patients who develop cancer, most of the time don't die from cancer. They die from an infectious component. Patients who have AIDS, they die from an infectious component. All of those things we hear about. You know, money, so much money goes into research for all of those disease processes, and yet the patients are going to die from an infectious component of that. The average mortality is about 30% overall. As you get patients who have higher comorbidities, patients that get older, things such as that, the mortality rate goes up significantly in those particular patients. Now, back when I was sitting in some of these seats and I was younger, actually I sat right over there where Dr. Sam was sitting as a medical student, we didn't really know truly what the true definition was. As a matter of fact, as I was a fellow, every day you'd get either a letter or you'd get a phone call. There was no email, there was no smartphones back when we were doing it. And people would call and they'd say, hey, do you have 5 minutes? I want to do a quick survey. And they would ask what my definition was for bacteremia or SIRS or something such as that. And after a while, they decided that in 1992 that they would get some of the biggest thought leaders in the country together from the ACCP and the SCCM, and they say, we have 6 definitions, and we want a consensus statement so that across the board, no matter where you practice, who you practice on, you will have the same definition across the board. And as you can see here, all the way down from an infection to SIRS, sepsis, severe sepsis, septic shock, and MODS, those are the definitions that came out in 1992. In 2001, Society of Critical Care Medicine got together again and said, let's relook at it. And they actually came up with something called the PIRO, P-I-R-O, definitions. And they actually threw that out there. Have you ever heard of it? Didn't work. We're still sticking with the definitions from 1992. They got together a couple years later, probably someplace, I think in Belgium. It was a very nice resort. I was not invited. I was extremely upset. But this time they took the ACCP, the SCCM, and they actually took the European Society of Critical Care, brought them together for one reason, to go back through the 6 definitions. And you know what? They said, people are finally on the same page. They left it alone, and then they went out and had a very nice time. So based on all of that, we know that there's a continuum when we look at the disease process. A patient will have an infection. Now, when we think about sepsis, we automatically think about bacterial infections. Keep in mind, most of the time it is, but it doesn't have to be. For those of you that were here this past December and January, that influenza epidemic that hit and put several people into severe, severe sepsis, ARDS, multi-organ failure, they were sick from a viral disease. You can see fungal diseases, you can see parasitic infections, all of which can start this particular disease process. Most of the time is it bacterial? Yep. But keep in mind it doesn't necessarily have to be. And then you have SIRS. SIRS is systemic inflammatory response. There are 4 criteria for SIRS. For those of you that are getting ready to take an in-service or take your boards, this is a very, very familiar question. They will give you a case scenario, and then they will ask you which of the 5 is not a SIRS criteria. And every single time they'll put blood pressure on there, and the patient will be hypotensive. SIRS criteria is due to inflammation. You're going to see alterations in temperature. Keep in mind, hypothermic patients are sicker than hyperthermic patients because they can't mount a thermic response. How many times have you seen that patient in the emergency department that comes in from the nursing home, their temperature is 35.4, and they're like, oh, their labs look okay, we're going to send them back to the nursing home. They're fulminantly septic. Don't send them home. Hypothermia is worse. For some reason, they've met several times and they still say tachycardia is greater than 90. Either they need to change the definition or we need to change physiology class in medical school. Changes in respiration, tachypnea. We've also added, in addition to tachypnea, we've added anybody that requires mechanical ventilation or anybody has a PaCO2 of 35 or less. And then alterations in white blood cell count. Now, just because a patient meets SIRS criteria does not mean that they are septic or that they are infected. It's an inflammatory reaction. I could ask you guys to go up to the stairwell, run up and down the stair from the ground all the way to 11, 4 or 5 times, those of you that survive, and come back in this room. Every one of you will meet SIRS criteria. You'll be tachypnic, you'll be tachycardic, you'll probably be hyperthermic because the stairwells aren't air conditioned, and you're going to demarginate, and you're going to have an elevation in your white blood cell count. Are you septic? Are you infected? No. It's an inflammatory response. But if you add infection to SIRS, then you get sepsis. If you add organ dysfunction to that, you now have severe sepsis. If that organ dysfunction is cardiovascular, despite appropriate resuscitation and the initiation of a vasopressor, you have septic shock. If you add multiple organs to it, you have severe sepsis with multi-organ dysfunction. Now, when we look at this disease process, we think of 7 different organ systems. And the importance of that is because when we think about it, everybody thinks about the big 3. Cardiovascular, right off the board. Respiratory, right off the board. And even renal. Those 3 are always discussed. But it's the 4 other organ systems that aren't discussed that you've got to keep in mind. Keep in mind, anything that alters level of consciousness or reduces the GCS is an organ dysfunction. Anything that elevates your liver functions is an organ dysfunction. And we talk about, back when I was younger, patients were septic with or without DIC. It was a whole different entity. They were septic and they had DIC, or they're septic and they didn't have DIC. We now know that's an organ dysfunction. As a matter of fact, we know that the degree of thrombocytopenia and the rapidity with which a patient hits that thrombocytopenia is indicative of outcome. The faster they drop their platelet count, the more likely they are not to survive this episode. And last but not least is metabolic. We measure lactate all the time. People think we're crazy. We measure lactate so often. But the level of hypoperfusion is an indicator of organ dysfunction. And the reason why knowing that there are 7 organs that we monitor is important is because as the number of organ failures increase, as does the mortality. When you have a patient that has 5 or 6 organs, their outcome is very, very slim. And that information is important because you're going to talk to families and they want to know prognosticators. And also when you start looking at resources, do you really want to initiate certain therapies on patients who have 6 or 7 organs down and their likelihood of recovery is slim, versus somebody that may have 2 or 3 organs down? You're going to work a lot faster and a lot harder to prevent the other organs from going down and going back in that particular direction and improving the patient's outcome. Now this is a grand rounds, and we could sit here for the next part and talk about all the little microvascular pathophysiology and all those microbiology and all those things that would even put me asleep. But we're not going to do that. What we do know that from a pathophysiologic standpoint, it's at the microvascular level, it's alterations in inflammation, coagulation, and fibrinolysis. And it's going to cause hypoperfusion because you end up with microvascular thrombi obstructing forward flow, and then you end up with global tissue hypoxia. And one of the things that's so important about this is that a patient may start with a urinary tract infection. They may start with a pneumonia, but all organs are going to be involved because it affects the microvasculature throughout the entire body per se. In 2004, the Society of Critical Care Medicine got together and they said that they were going to come up with a surviving sepsis campaign, which they did. And it took off and people were told to do this, that, and the other. But when you actually looked at it, there were actually 5 tiers related to care and what you should be doing based on evidence-based medicine grade, A through E. And it was kind of complicated and kind of confusing. And people were like, well, maybe I'll do it, maybe I won't do it. Is that an A, is that an E? What should we actually do? So they revised it in 2008 to see the bundles that everybody's very familiar with. The resuscitation bundle, which we're supposed to complete in the first 6 hours of a patient's presentation, followed by the management bundle, which is supposed to be completed over the next 24 hours. Now, in 2012, and we'll go through that in just a few minutes, they actually revised these bundles again, and I'll show you what the changes were from there. But the interesting thing is when you look at the 2 bundles, everything that is on the resuscitation bundle, nobody argues with. There's not a lot of controversy to it. Nobody argues that as soon as you see a patient, you should start resuscitating that particular patient with either a colloid or a crystalloid, your choice. Nobody argues that you should get cultures and start antibiotics. Check a lactate. If you need radiologic imaging, go ahead and do that. You need source control. If there's an abscess, like I always tell my house staff, one thing I learned as a 3rd-year medical student, I remember to this day, is beaten into my head, never let the sun go down on pus. You got an abscess, you drain it. You don't wait. You drain it as you're resuscitating that patient to provide stability. And then ways to monitor your patient's resuscitative techniques. Nobody argues any of those things. There's no controversy related to it. The controversy comes in to the management bundle, and that's what I want to talk about. Now, when we get to 2012, like I said, this has been revised. The interesting thing is everything kind of stays the same except they changed the title of each of the particular bundles. It's still 6 hours, still 12 hours. And I'll tell you a little, 24 hours, excuse me, and we'll talk a little bit about that towards the end. But when we look at resuscitation and we think about severe sepsis, the first study that should pop into any intensivist's head is a study done by Manny Rivers back in 2001, his early goal-directed therapy study. Now, whether you're a proponent of EGDT or you're not, that's a personal choice. Keep it, do whatever you want. It's not really up there with politics and religion for things that you shouldn't talk about with people, but you have people that kind of go on both sides of the fence when it comes to EGDT. But you can't argue the fact that this really revolutionized how we were treating and resuscitating our sepsis patients very, very early on. And the thing that's interesting about this particular study that I think is important is that when these patients were randomized in the emergency department in Detroit, they were started within 1.4 hours after arrival. These weren't patients that were admitted to an ICU 24 to 48 hours later, oh, they randomized in, let's go ahead and start the study. These people hit the door to the ER, the diagnosis was made based on SIRS criteria and hypoperfusion with a lactate, and they were automatically randomized and moved to a separate section of Manny's ER, and study was started down there. What they were looking at was half the patients were put on the early goal-directed therapy arm, half the patients received standard therapy. Interestingly, the first 6 hours, patients that were in early goal-directed therapy, as you know, received more fluid. Over the next 66 hours, by the time the patients finished up in the ICU, the difference was 103 cc's between the two groups. Now, did it really matter? I mean, you ended up with the same amount of fluid. It mattered significantly. The difference in mortality was somewhere between 13 to 16%, depending upon the number of days that you looked at. And your in-hospital mortality was a 16% improvement by initiating early goal-directed therapy. Now, when this first came out, everybody thought Manny a genius, Bryant Wynn a genius. These guys were fabulous. Everybody should be doing this. And everybody jumped on the early goal-directed therapy arm. The problem was our friends at ARGNet. And those of you that are familiar with ARGNet, kind of familiar with some of our opinions of ARGNet. Now, and based on that, our guys at Bandy said, well, that's interesting, but we don't agree with it. We don't really think that early goal-directed therapy is accurate, and we don't really think it's helpful. And as a matter of fact, we're going to do our own trial called the FACT trial, where we're going to look at it and we're going to prove that volume is not the answer to these particular patients. And they did. So what they did is they took a look at patients in the ICU on an average of 43 hours after admission and 24 hours after the patients developed acute lung injury. A couple things right there. Number one, these were not all severe sepsis patients. These patients had acute lung injury. Remember, Manny's patients were all severe sepsis, and they were initiated within 1.4 hours of presentation. Some of these folks were up to 43 hours later. When they looked at the study and they randomized them to either conservative or liberal resuscitation, they found that across the board there was no statistical difference in mortality versus the 16% from the early goal-directed therapy study. But they did say that conservative fluid improved significantly organ function and decreased length of stay, which is great. So the question that came out is, which study is actually accurate? And the answer to that really falls upon the timing. If you're seeing a patient in the emergency department and you're seeing a patient that just decompensated, early goal-directed therapy is what you want. You want to initially volume resuscitate your patient to the point of optimized perfusion. If you're seeing a patient 43 hours later, well, the horse is out of the barn. At that particular point in time, you don't want to volume resuscitate them too much. You don't want to overload them because, remember, this is an acute lung injury study. Those patients, remember, your ALI, your ARDS patients, you want to run them drier so that the organs function better, the lungs function better. So the answer to this would be you want conservative management. So what's the best study? I don't know. Claire Murphy and their group took a look and said, you know what, I'm going to take the best of both worlds. I'm going to take a group of patients that have developed acute lung injury from severe sepsis, septic shock. I'm going to randomize them to 4 groups. And each of the groups, the amount of fluid that they get is going to be different. Some of the patients are going to get adequate resuscitation early, but conservative late, or conservative and then liberal, and something in between. And what Claire actually found is she found that the mortality rate was 18% in the patients that were aggressively volume resuscitated early but conservatively managed late versus 75% for the exact reversal and somewhere in the middle. So the answer to the question, I think, comes up that it's not controversial, it's where are you at that point in time in your patient's care. If you're seeing them early, well then you want to lean more towards EGDT. If you're seeing them later and they have ALI or ARDS, or if you look at the new Berlin definition, they all have ARDS, it's just depending on whether it's mild, moderate, or severe, you want to use more of a conservative management. So there's a lot of controversy there, but I think the answer to the question comes in, where is that particular patient? Now another question comes in, well, what do we resuscitate them to? You know, in the River study, we used SCVO2, and everybody was resuscitated to 70%. Why 70%? Pope and their group randomized patients and actually found the lowest mortality rate with what they called normoxia versus one of the other two. Other questions came out was, again, with Manny's study, every one of those patients received an SCVO2 catheter, and they maintained the SCVO2 greater than 70% for continuous monitoring. Do we really need to do that? Why can't we just put a central line in and just draw through the distal port and run the number PRN intermittently when we need it? Well, according to Smith and their group, they looked at almost 300 patients, and they found that hitting that 6-hour window, that resuscitation bundle window, if you did it continuously, you improved your mortality rate by 16%, 15-16%. If you, excuse me, let me reword that. To meet that 6-hour window, you improved it by 16%. Your mortality dropped by 12% if you did it continuously. And last but not least, Ortega and their group said, okay, let's look at every aspect of that resuscitation bundle. And is any of them clinically significant that if we only did one, what would our outcome be? And again, the answer was right down here, is that if you hit that resuscitation bundle, reach that SCVO2 of 70%, it was the only one of all the variables that was clinically significant to improve mortality. So again, there's a lot of controversy out there related to the early goal-directed therapy study. But when you look at the data shows that it works. And therefore, in my mind, there's not a lot of controversy related to that. This study just came out. This is the process trial. The process trial came out of UPMC. And UPMC's goal was to prove that a single center study for EGDT was not accurate. And that no matter what you did, however you looked at it, that data was not appropriate and that's not what we should be doing. As a matter of fact, they randomized patients to 3 groups. They used the protocol-based early goal-directed therapy arm, they used the protocol-based standard therapy arm, and then they just used usual care. Usual care just being whatever you as a clinician would usually do to take care of these particular patients. And what they found was that across the board, there was no statistical difference in mortality. So the answer then came out that since process, early goal-directed therapy does not need to be done. It doesn't make a difference. So let me ask you this. So in the last 12 to 13 years, we've been practicing some component of early goal-directed therapy to resuscitate, to optimally resuscitate our particular patients. Now, if you take the knowledge that we have since 2001 into our current practice, that's standard of care. So when you compare standard of care to this quote-unquote protocol, it's the same thing. We're doing the same thing. When we're seeing patients in the ER that are coming in septic, or patients that we're seeing in the ICU that are coming in septic, we're culturing them. We're giving them antibiotics. We're checking lactate. We're volume resuscitating them. We're looking at some sort of resuscitation target that we're shooting for. We're doing all of those things. So if you take that as usual care, put it against Manny's protocol, guess what? You're not going to see a difference in outcome. You're not going to see a difference in mortality because you know what? He taught us what to do. So again, if you believe in it, great. If you don't, that's great too. But don't let anybody tell you that process rules out 12 years of studies, because it doesn't. It proves, if you actually read it, process proves that the 12 years of studies, that evidence-based medicine that we've had actually is accurate. And he's taught us how to take care of these particular patients. Another thing that we do a lot of when it comes to the severe sepsis patients is we check procalcitonins. We check PCTs on everybody. You could come in with a fractured femur and what the heck, we'll probably check a PCT on you, just because that's what we do. Well, the study du jour is the Pro-Rata trial. And the Pro-Rata trial looked at whether following PCT was going to change outcome when we looked at antibiotic management in the ICUs. And what they did is they randomized patients based on what their initial procalcitonin levels were. If they were unsure clinically, if the physician was unsure clinically, saying, well, my level's low, but I really think something's going on, they were allowed to repeat it at 6 to 12 hours. And they continued antibiotics up until the point in time when their PCTs dropped and followed this particular algorithm. Now, across the board, there was no difference in mortality, whether you follow procalcitonin or not. There was no difference in mortality. Okay, there you go. Clinically, no difference whether you did it or not. But that's not why we follow procalcitonin. It's not why we're looking at it. What we're looking at it is who needs antibiotics and who doesn't. You had a significant change in duration of therapy for antibiotic days. So by following procalcitonin, you will actually decrease your antibiotic usage. Doesn't change your outcome, but it decreases your length of stay, decreases your cost, decreases your antibiotic usage, and in the long way, actually decreases your resources and things such as that. It may decrease resistance and therefore in the long run may actually improve outcome in certain patient populations. I think one of the biggest things for me that I did not like about Manny's trial was that he wanted to push hemoglobin. He wanted to push that H&H to 10 and 30. And we all know that there is no trigger. There is no transfusion trigger in critical care. There just isn't. You know, as long as the patient is perfusing, they have a normal lactate, their oxydynamics are normal, it doesn't matter if their hemoglobin is 7 or 12. There's no reason to push it if they're perfusing properly. And in Manny's study, you did have to push it. You did have to transfuse from there. And one of the reasons that we don't like it is because of this, the two-hit theory. And the fact is, can the bioparticles in the red cells cause injury to the cells themselves or to the organs? And older cells don't have the deformability, and when they go through the capillaries, it can cause obstruction. It causes obstruction, it causes hypoperfusion, you get more trouble from there. So the question comes up, and I think the biggest question that when process started, the big question that the guys at UPMC were actually asking for process was, do we really need the transfusion part of it? It evolved into what you saw, but that was the initial question. And my answer is no. I don't think we need to transfuse all these people, but if we do, if you have a patient who is hypoperfusing, a patient who has decreased oxygen delivery, oxygen consumption, call the blood bank and ask for the youngest blood that they have. Remember, they keep blood on the shelves for 42 days. And if you've got a GI bleeder, you've got a mass cash transfusion that you're doing for trauma, then whatever blood they can grab is fine. But if you're looking specifically for that severe sepsis patient, that you're looking for O2 carrying capacity, and you need it for perfusion and to improve your oxygen delivery and your oxygen consumption, call the lab and ask them to give you the youngest blood that they've got. You want something less than 14 days old because it's got the best hemoglobin carrying capacity and the cells are deformable. They're going to go through the capillaries without any problem. So pick up the phone and say, hey, I need 2 units of blood for this patient. This is why I'm using it. Can you please get me the youngest blood? And they'll give it to you. Otherwise, if you actually look at this, if you look at the bags when the nurses are calling and going through it, you know what they find? It expires in 2 hours. It expires today. They give you the oldest blood that they have. So always call and ask for the youngest from that particular standpoint. We talked about the fact that the timing of antibiotics is extremely important. Why? Because we know that the earlier that you give antibiotics, the better the patient's outcome. And we also know that you've got to use the right antibiotics, because if you don't, you increase the mortality. Now, one of the things that differentiates between severe sepsis and septic shock is the ability to volume resuscitate the patient without the requirements for using a vasopressor. If you need a vasopressor, you've got septic shock. So which vasopressor should we use? The VASST study actually looked at vasopressin versus norepi. And what they found, clinically, there was no difference in outcome between the two. Yet, we use norepi. Question comes out, okay, what about dopamine? We used to use dopamine all the time. What about dopamine versus norepi? SOAP trial took a look at that. Look at that, clinically, there's no difference between the two. Except, if you look at side effects, and I apologize, I cut it off, this is dopamine, this is norepi. Your dysrhythmias in relation to dopamine is twice as high. And if you actually look at your hazard ratio, it all falls under the norepi is actually better than dopamine from there. So what should we use and why? Well, we've changed the bundles. They're now called the initial resuscitation bundle and septic shock bundle. They're no longer the resuscitation and maintenance bundle. SCVO2 is part of both bundles. No matter what we do, we cannot get CVP off of the bundles. That makes Dr. Walter very happy. Also, instead of just doing 20 cc's per kilo, the recommendations is now 30 cc's per kilo of crystalloid or colloid equivalent from that standpoint. Can we use the dynamic parameters? Can we use SVV? Can we use PPV? Absolutely. It's now part of the shock bundle. Antibiotics, again, I tell you, for every hour that you delay, your mortality rate goes up by 5%. Lactate, 1A. PCT, still not supported. It's getting there, guys, but as I showed you, it decreases length of stay and antibiotic usage. It doesn't change mortality. There is no trigger for hemoglobin. They do recommend less than 7. You will start to see hypoperfusion and oxydynamic issues, so they do recommend transfusion for less than 7. Now, when it comes to which vasopressor we should use, don't use dopamine. I know we get patients transferred all the time on dopamine. Don't use it. Your initial vasopressor is norepi. Start with norepinephrine. If you see yourselves using increased amount of norepi, to me, once I get to 0.3, 0.4, I start thinking, is my patient vasopressin deficient? We have shown in studies that septic shock and severe sepsis patients are actually vasopressin deficient. That's why it doesn't work as a vasopressor per se, because it causes too much issue with ischemia to the gut at higher levels. But most patients with severe sepsis are going to be deficient. Put them on 0.02 to 0.04 units per minute for continuous infusion for about 6 to 12 hours. And the bulk of those, you will replete what they are lacking in vasopressin, and you will see a decrease in your your norepi requirements. If after you do all that and they're still hypoperfusing and they need a second vasopressor, the second vasopressor is actually epinephrine. Now, there's some controversy as whether or not we should use steroids. The answer is yes. If we are using steroids, how should we use it? For years, we either used hydrocortisone 50Q6 or 100Q8. The recommendation is now continuous infusion of 200 milligrams over 24 hours. And the rationale for that is very simple. No peak and valley effect. Continuous infusion, and you don't have problems with your adrenals, and it works a lot better that way, and will decrease the amount of vasopressor usage that you have. This is a really nice little algorithm that Merrick made out, and it just kind of follows from the initial presentation and just kind of follows it down what you should be doing, everything we just talked about from that particular standpoint. So, going ahead and pulling my head out of you-know-what, I do have a few more minutes. I do want to talk a little bit about resuscitation. And we're able to make our diagnosis of severe sepsis or septic shock, but what is the actual definition of shock? And this is something that you have to be able to make that paradigm shift. Because for years, shock in everybody's mind was hypotension. If they didn't have a MAP of 65 or greater, they were in shock. The definition of shock is failure to deliver and or utilize adequate amounts of oxygen. Shock is a definition of hypoperfusion, not hypotension. It's as simple as that. How many patients do you guys see a day that have blood pressures of 80 or 90 systolic and they have a normal lactate? Saw one this morning. They're yelling and screaming. It's got to move to the unit. The lactate's 1.4. What am I going to do for her? She's perfusing fine. 9% of Manny's patients had blood pressures greater than 140/90, and they all had lactates greater than 4. So it's not pressure, it's perfusion. And therefore, how we assess our patients and how we resuscitate our patients and the targets that we're looking for should all actually be based on perfusion and not pressure. What are we going to see? We're going to see different levels of shock. Hypoperfusion at the circulatory level is what we just talked about, those 7 different organs that are getting hypoperfused. As that hypoperfusion worsens, we start to see dysoxia. Dysoxia is the new term for cryptic shock. How many patients do we see that we start to volume resuscitate them and their vital signs improve, their blood pressure improves, their heart rate improves, their mentation may actually get better. But we stop that fluid, the boluses that they're getting, we put them on maintenance fluid, and all of a sudden they tank. Why do they do that? Because the critically ill patient shunts their blood from the non-dependent or the non-important organs to the important organs. The 2 most important organs are the heart and the brain. So when you volume resuscitate, you bolus resuscitate, that fluid goes to the heart and the brain. They wake up. Their vital signs improve. But it shunts it away from the non-vital organs, such as the GI tract. And then what you end up having is you end up having patients who are still hypoperfused, their lactate is still up, but their vital signs look a little bit better. You stop that bolus, all of a sudden they crash. They're dysoxic because they're still hypoperfusing. We need to follow their lactates. And then we get down to the microcirculatory level, which is where we start seeing lactate forming. We start seeing the cells shifting from aerobic to anaerobic metabolism, and those mitochondria that through their Krebs cycles making 38 ATP per cycle that are sitting there saying, bring it on, we got this, to all of a sudden shifting to anaerobic metabolism. They're making 2 ATP per cycle, and all of a sudden those cells are starting getting dysfunctional. And as cells get dysfunctional, organs get dysfunctional, and that's how patients start to have organ dysfunction, and they pass from there. So why do we follow lactates? Because lactate is what we can see. The end point in actuality, when you look at the Krebs cycle, isn't lactate. It's actually pyruvate. But the pyruvate assay is not stable for the bedside. So you shift down, and lactate is the next step. And lactate is stable at the bedside, and we can measure it. And as we look at the clearance of lactate, we can show that as our lactate clears, our patient's survival improves. For example, if with proper resuscitation, you can get your patients to normalize their lactate in the first 6 hours, their survival is 93% versus 67%. If you can get them to clear by 50%, you still get a 90% survival. Less than that, your survival starts dropping off. So that's one of the reasons that we follow lactate so much, is we want to know where we're starting, we want to know how hypoperfused, how anaerobic our patients are, and from there, what's our resuscitation doing? Are we doing the right thing? Other ways that we look for fluid responses is we look for a target for our optimization of our fluid management. And as you've noticed multiple times today, I've used the word optimization, not maximize. Don't maximize, optimize. There's a big, big difference. You can give somebody may need 30 cc's per kilo. But heck, man, there's another 600 cc's in that bag. Let's just give it to them, maximize them. Don't do that. Optimize them. And we used to measure things as pulmonary occlusion pressure and CVP. The problem with that is it's not always accurate in our patient population. And as a matter of fact, only 50% of patients that we fluid resuscitate, volume resuscitate, actually have a positive response. The other 50% have no response or actually is detrimental, and they end up with organ dysfunction. So the question is, for years we've used pressures, we've used CVP, we used blood pressures, we used pulmonary arterial occlusion pressures, and those were our targets. And we did a pretty good job. We weren't sucky docs. We did a pretty good job when we used our PA catheters. But we're learning that they may not be the best way. And the reason for that is because the heart works off of Starling's curve, Starling's law. Unfortunately, Starling's law doesn't relate to diastolic pressures, it relates to volumes. So we should be measuring volumes. So the regular curve, as we know, as we improve the patient's volume status, they are preload dependent. As they are preload dependent, we improve our stroke volume. When we get up here and they are volume optimized, they are preload independent. And we know that once we get here, giving more fluid is not a good thing. And I told you that 50% of the patients respond, 50% don't. Now, one thing that we never see on the Starling curve is what actually happens here. If you keep pushing fluid and maximizing it, it does this. It comes right off the other side. So that's why you want to optimize, not maximize. Now, unfortunately for us, we're not lucky. We don't get to see the normal heart. A lot of times we see the failing heart. It has a very, very short preload dependent phase and has a very long preload independent phase. And these folks are not going to respond to a volume challenge to improve their stroke volume. They actually need some sort of vasoactive substance, either a vasopressor or an inotropic agent. But again, those aren't that complicated to figure out. It's what we see every single day. It's everybody in the middle. Where are they on their Starling curve? Are they preload dependent or are they preload independent from there? And that's what we need to figure out. That's why we need some form of resuscitation guideline. We need some sort of tool to tell us what we should use. Everything from non-invasive as palpating a pulse all the way to putting in a PA catheter, doing a TEE. Well, there's a bunch of stuff in the middle. And it is probably a good place to stop, I think, because this is a whole nother lecture that I'd be more than willing to give should you provide lunch, but be more than willing to give at that particular point in time. So I think I'm going to leave you guys wanting more and open it up to any questions that you may have, because this is a whole nother lecture that would take a good 45 minutes to do a good thorough job, and I'd kind of like to stop here just to whet your appetites and make you come back for another sandwich another time. So, are there any questions?
Let me ask you about lactate. Any work in like measuring lactates for different organs? Like the lactates you measure, that's kind of all like combined.
Correct. Yeah, I actually I had that exact conversation with Horatio D'Agostino not that long ago. And I asked him, I said, is there any way, because there's no studies out there that we can do at the bedside, that kind of stuff. And I asked him, I said, is there any way in some of our sicker patients that we could actually put catheters in and actually measure lactate, you know, like measure lactate in the renals or measure lactate, you know, in a different organ, just to see if we're truly perfusing those organs and or not. You know, is it a general, say our lactate's 3.5, although that's an elevated lactate? Is it because the liver's sick and it's just not metabolizing the lactate? Or say, is the kidney just not getting the perfusion it needs and I need to push it harder, I need to give it more inotropic support? And we talked about it. He thought it was a great idea, you know, oh Laurie, that's very good. And but right now there's just no way to do it at the bedside. But that we actually talked about it, how that would be very helpful to determine what we're doing and whether or not it's working or not. Dr. Chu?
Yeah, Laura, first of all, I want to congratulate you and thank you and your team, such as Dr. Holliday, Dr. Robert Walker, who's here, for helping us, at least our division, Surgical College, and certification that you all done amazing year for. I just have a couple of questions. Maybe one question and a comment. The first question is, do you still do fluid challenge generating a Starling curve when you're not really sure about the patient's fluid status?
Yes.
Okay.
I mean, no matter what I say, what I, you know, it's kind of like do what I say, not what I do, kind of thing.
Right.
But we initially, when we first see a patient, we will routinely, unless it's just obvious, we'll give a fluid challenge. And we're more of a colloid group. Speaking for myself, I think both Bob's do the same thing. Is we'd rather give a colloid challenge. This way, we know it's going to stay intravascular. And if they really don't need that much volume, we're not going to cause that much trouble. And if we're doing that, we're getting that started, we can grab ultrasound and look at their IVC or go ahead and talk about some of this other stuff we can talk about at another time. But yeah, initially, we do give a fluid challenge to see how they respond.
Yeah. And the other comment I would like to make is I've seen it, and I can't explain, but there are patients out of blue become very, severely septic. And our teaching has always been, there's a source. If you don't control that source, you can do all the fancy stuff, it's not going to help.
Right.
But on occasion, we just can't find the source, and on occasion, when we do culture them, we just can't find anything growing.
Yeah.
And then vice versa, I've also seen where the patient may have a very minor, in our opinion, reversible correction, maybe a small leak, whatnot, and then within 24 hours, they're 6 feet under. So, in your literature, do you see such a gradation, and how do you explain that?
Actually, we do. As a matter of fact, one thing that we always think to ourselves is about 50% of patients you never find the source. 50% you just don't have a clue why they're doing it. And actually, in the medical literature, they're starting to do so much research now at the DNA level that they can actually name certain areas of the DNA that if a patient actually has, that you can inject them with all the LPS you wanted to, and they cough at you for 24 hours and they would be fine. And other patients, based on their DNA, they can just get just a nick of something and they're going to become fully septic and die. And what they're looking at some of this literature, some of this research, is actually instead of using, everybody gets this, is depending upon what your DNA profile is, you're going to get this cocktail for the first 6 hours, and then at hour 7, we're going to give you this, followed by this, and it's all going to eventually be based on your DNA. And the assays that they're actually looking at now, they're trying to figure out a way to do that so that your treatment is going to be mandated based on your DNA. So it's actually really kind of very scary. It's kind of like, in Neil's Star Trek where they just kind of wave that wand over you. It's kind of heading in that direction where they just take a drop of your blood, look at your DNA, and based on your DNA profile will come out what you get at what particular point in time. I mean, we're nowhere near that, but that's what's coming.
Wonderful. Thank you.
Thank you. Yes, Dr. Roy?
Yeah, Dr. Grier, I know that, and I apologize, I was being a patient instead of a doctor, and I missed the talk. But the comment about colloid versus crystalloid, in the surgical literature, that one sort of does like the taking spleens out in trauma. It goes back and forth and back and forth. And one of the studies that has been long enough ago that most of the people in this room were not either alive or involved in medicine when it was done, was looking at measuring lung water via cannulation of the lung lymph fistula versus thoracic duct in the baboon model, and then doing colloid versus crystalloid resuscitation, and then doing necropsy and lung waters in the era of Da Nang lung, followed by on and on and on. The debate where Francis Moore was on the colloid side and young upstart was on the crystalloid side, pretty convincingly showing that while the colloid reduces peripheral edema, it actually increases the lung water because of the gap junctions in the endothelial bed and the capillary bed in the lungs are so much larger. What's the medical literature, say on that? Because that's, again, in the surgery side of things, it's still pretty convincingly, and the stable isotope data show that colloid resuscitation increases lung water.
I think if you look at any literature, if you pulled 100 evidence-based medicine articles, 50 are going to be crystalloid, 50 are going to be colloid.
Yeah.
It's as simple as that. And you basically have to pick a side. And you missed it. It's one of the things, it's kind of like politics and religion. You're either crystalloid or colloid, one of the two. We're a colloid unit. I'll give 2 or 3 liters of crystalloid, and then I usually shift over to colloid. I kind of use a bit of a combo pack for me.
I think one of the differences in fairness between your unit and our unit is the caveat in the I think the open-minded crystalloid group is that if you have somebody that comes in with an albumin of 1.2, then you're actually not resuscitating them with colloid, you're actually returning their nutrition. You're providing them with nutrition and something they're deficient in, which is a whole different ballgame. And we tend to get people who are doing recreational pharmacology as opposed to who have been on medicational pharmacology for an entire lifetime and are now at the end of that. So you get albumins of 1, we get albumins of 5.
Right. It's all based on the patient population. But again, you know, each group, when you look at the literature, I mean, I know surgery, most of the literature for surgery is based on crystalloid. If you look at medicine, a lot of our stuff is colloid based.
Yeah.
And again, it's 50-50. You just, you know, I could pull 3 articles for you that show colloid is better. You can pull 3 articles that says crystalloid is better from the same, you know, the same journal.
Yeah,
so
yeah.
Nobody knows the answer to that, and that line's been drawn in the sand for 100 years, and it's not going to change. And everybody has their belief, but
yeah. I do think the patient differences probably play into that, and that's how I see the it's kind of like the pressors medicine patients. We tend to get people with pretty healthy hearts. Y'all tend to get patients that their hearts maybe not so much.
Right.
And so they're different. Shock is a different phenomenon in those 2 groups.
I agree. No argument. Ma'am, did you have a question?
Yes, on the nursing aspect, when you mentioned about the blood transfusion, that we should not get blood that's going to expire within 24 hours. Is that initial or throughout the treatment process?
It depends on what you're transfusing for. Again, if you've got a patient, you've got a GI bleeder that you're just trying to give blood to, it doesn't matter how old the blood is. If you've got a patient that's critically ill with severe sepsis, get the youngest blood that you can get.
That's for each time we order? Each
Yes.
time it's ordered, we should
Yes.
ask the lab
Yes.
for the...
Yeah, if you don't care, if it doesn't matter, then you don't need to call the lab. But if you're transfusing somebody that's critically ill and you need the formable cells, you need young cells that are healthy and are carrying, a good carrying capacity, every time you transfuse, then yes, you should call. Yes, Dr. Kirby.
In this complex situation, how much consideration does nutrition deserve, particularly micronutrients, since magnesium is many enzymes require magnesium, vitamins as cofactors?
Very good question. Actually, part of our admin orders is nutrition. We feed everybody, unless there's a significant contraindication. There are severe sepsis patients. Part of our admin orders, they all get fed. Absolutely. Nutrition is extremely important. Because if you get behind the 8 ball, they're not going to make it. Absolutely. Yes, sir. Thanks, you guys. Have a great day.